Every single day, your skeleton is being quietly dismantled. Not dramatically, not painfully, not in a way you would notice on a Tuesday morning while making coffee. Just a slow, invisible cellular withdrawal that has been happening inside you since your mid-30s, and that no amount of calcium supplements, no number of glasses of milk, no well-intentioned dietary adjustment has been able to fully stop. Because the problem was never what you were eating. The problem was what you were not doing. And what you were not doing takes 30 seconds. No equipment, no gym, no special shoes, nothing but the floor beneath your feet and the weight your own body has been carrying around for decades without ever once being asked to do something useful with it. What I am about to show you is not a wellness trend recycled from a fitness magazine. It is a mechanical signal. One that your bones have been waiting for your entire adult life, and that modern living has almost completely eliminated. 30 seconds a day is enough to deliver it. The science of why that is true is more surprising than the exercise itself. Start with what bone actually is, because almost everything the average person believes about bone is wrong, and the wrong belief is precisely why so many people over 50 are losing the structural foundation of their own body without realizing it until something breaks. Bone is not static. It is not the hard, fixed, permanent scaffolding that the word implies. It is living tissue, metabolically active, continuously remodeling, perpetually being broken down by cells called osteoclasts and rebuilt by cells called osteoblasts in a cycle that never stops from the day you are born to the day you die. In youth, the osteoblasts win. Construction outpaces demolition. Bone density accumulates. Peak bone mass is typically reached somewhere between 25 and 30 years of age, and the architecture built during those years becomes the structural capital the rest of your life draws on. After 35, in most people, the balance shifts. Osteoclast activity begins to outpace osteoblast activity. The demolition crew starts arriving earlier than the construction crew. Net bone mass begins to decline, slowly at first, accelerating after 50, dramatically accelerating in women during the years following menopause, when the estrogen that had been partially suppressing osteoclast activity withdraws, and the remodeling cycle tilts sharply toward loss. By 65, a woman who has done nothing specific to address this process may have lost 20 to 30% of the bone density she had at 30. The loss is not visible. It produces no pain until the architecture fails. A hip fracture, a vertebral compression, a wrist that breaks from a fall that should have produced nothing worse than a bruise. The first symptom of bone loss for too many people is the fracture that reveals it. But here is what the medical conversation about bone loss almost always misses. The conversation focuses on calcium, on vitamin D, on hormone replacement, on bisphosphonate medications that slow osteoclast activity. All of these interventions address the chemistry of bone remodeling. None of them address the primary signal that drives osteoblast activity in the first place. That signal is mechanical, and it has a name: Wolff's law. Formulated by the 19th century German surgeon Julius Wolff, it states that bone adapts its structure in response to the mechanical loads placed upon it. Where load is applied, bone is deposited. Where load is absent, bone is withdrawn. The osteoblasts, the cells responsible for laying down new bone matrix, are mechanosensitive. They respond to mechanical strain. They are activated by it. They rest without it. This is not a hypothesis. It is one of the most thoroughly validated principles in musculoskeletal biology. The evidence for it is everywhere once you know to look. The dominant arm of a professional tennis player has measurably greater bone density than the non-dominant arm. Astronauts returning from extended periods in zero gravity show significant bone loss despite adequate nutrition because mechanical loading has been removed. Patients confined to bed rest lose bone density at a rate that no dietary intervention fully prevents. The skeleton is not a passive structure. It is a dynamic system that continuously calibrates its own density to match the mechanical demands being placed on it. Give it demand and it builds. Remove demand and it dismantles. The modern lifestyle for most adults over 50 has progressively removed demand. Sitting at desks, riding in cars, walking on flat, even surfaces that provide minimal impact. The skeleton of a 55-year-old living a contemporary sedentary life is receiving a clear mechanical message. The message is, we do not need this much structure here. And the skeleton, faithfully following Wolff's law, obliges. The question then is what kind of mechanical signal actually activates osteoblasts? Because not all loading is equivalent. Slow, sustained, gentle loading, the kind produced by leisurely walking on flat pavement, produces some mechanical strain but not enough to trigger meaningful new bone formation in already established adult skeletal tissue. The osteoblasts require a specific stimulus. They respond most powerfully to dynamic, high-rate loading, forces that rise quickly, peak sharply, and transmit through the skeleton rapidly. Impact. The kind of brief, sharp mechanical event that sends a pressure wave through bone fast enough that the mechanosensitive cells embedded in the bone matrix, the osteocytes, register it as a genuine structural demand. Osteocytes are the sentinels of bone tissue. They sit within the mineralized matrix in small cavities called lacunae, connected to each other and to the bone surface through a network of microscopic channels called canaliculi. When mechanical strain bends or compresses the bone matrix around them, fluid shifts through the canalicular network and the osteocytes detect that fluid movement. They translate it into biochemical signals, signals that recruit osteoblasts to the surface, signals that initiate new bone formation. The entire cascade begins with a mechanical event sharp enough to move fluid through the canalicular network at a rate the osteocytes register as significant. Slow loading does not move fluid fast enough. High-rate impact does. This is the fundamental biophysics of why the type of loading matters as much as the fact of loading. And it is the reason why a specific, simple 30-second exercise produces bone-building signals that an hour of gentle walking cannot match. The exercise is heel drops, also called heel raises followed by heel drops, or in the clinical literature, heel impact loading. The mechanics are straightforward. Stand flat-footed, rise onto your toes, then drop back down onto your heels with enough deliberate force that you feel a clear impact travel up through the heel, through the ankle, through the tibia, through the femur, through the hip, and into the lumbar spine. That impact, that brief, sharp transmission of ground reaction force up through the axial skeleton, is the mechanical signal. The rate of force development during a controlled heel drop, the speed at which the force rises from zero to peak, is approximately 10 to 20 times faster than the rate of force development during normal walking heel strike. The osteocytes embedded in the calcaneus, the tibia, the femoral neck, and the lumbar vertebrae register the pressure wave. Fluid shifts through the canalicular network. The biochemical cascade initiates. Osteoblasts are recruited. Bone formation begins. The intervention sounds almost insultingly simple for something producing that chain of events. But the simplicity is the point. Evolution did not require complex equipment to maintain skeletal density. It required impact. The impact of running, of jumping, of carrying loads across uneven ground, of the 1,000 daily physical demands that modern life has systematically eliminated. The heel drop is a deliberate reintroduction of the mechanical stimulus that your skeleton evolved to receive, and that contemporary living has taken away. The clinical evidence for this is specific, and the effect sizes are not modest. A study by Weeks and Beck, published in the journal Osteoporosis International, examined the effects of heel drop loading on bone density in postmenopausal women. Participants performed 50 heel drops daily. Bone mineral density at the hip, one of the two skeletal sites most vulnerable to osteoporotic fracture, showed significantly attenuated loss compared to controls over the study period. The mechanism was exactly what Wolff's law predicts. The high-rate impact loading was delivering the mechanical signal that osteocytes require to initiate the bone formation cascade. A separate line of research by Bassi and Ramsdale established that brief daily sessions of high-impact loading produce significantly greater increases in hip bone density than equivalent periods of low-impact exercise in premenopausal women, and that the effect persisted into the postmenopausal period when women who had performed impact loading during earlier years retained measurably greater hip density than those who had not. The skeletal architecture built in response to mechanical demand is not lost immediately when the demand is reduced. The bone that impact loading builds accumulates. It compounds. The woman of 55 who begins heel drops today is not simply slowing her current rate of loss. She is introducing a stimulus her skeleton has been deprived of for years, and that the osteoblast population within her bone tissue will respond to because the mechanosensitive machinery is still functional. It has simply been waiting for the signal. The hip is the site that matters most in this conversation, not because other skeletal regions are unimportant, but because hip fracture in adults over 65 is not a minor medical event. It is a life-altering one. Approximately 20% of adults who sustain a hip fracture die within 1 year of the injury, from complications including pneumonia, deep vein thrombosis, and the cascade of physiological decline that prolonged immobility initiates in an aging body. 50% of those who survive never return to the functional independence they had before the fracture. The hip fracture is the skeletal failure that changes the trajectory of a life, and the femoral neck, the narrow strut of bone connecting the ball of the hip joint to the shaft of the femur, is precisely the site where bone density loss concentrates in aging adults and where high-rate heel impact loading delivers its most clinically meaningful signal. The transmission path is direct. Heel contacts ground. Ground reaction force travels up through the calcaneus, through the ankle mortise, up the tibia, across the knee, up the femoral shaft, and into the femoral neck. Every heel drop sends a mechanical signal directly to the site most at risk. No machine targets it more precisely. No supplement reaches it more directly. The transmission is anatomical, immediate, and free. The lumbar spine receives the signal too. Vertebral compression fractures are the second most common osteoporotic fracture, and they are the ones most likely to go undiagnosed because they often produce only chronic, diffuse low back pain that is attributed to muscle strain, poor posture, or the general discomforts of aging rather than to a structural failure of the vertebral body. The axial loading that heel drops transmit up through the lower extremity, reaches the lumbar vertebrae, and delivers the same high-rate mechanical signal that the osteocytes in the femoral neck are receiving. The osteocytes in the lumbar trabecular bone register the fluid shift in their canalicular network and recruit the same osteoblast cascade. The spine and the hip are both addressed by the same 30-second daily practice. No exercise equipment required, no loading machine, no weighted vest, though a weighted vest does amplify the signal and is worth considering as adaptation progresses. The floor and your heels are sufficient to begin. Now the hormonal dimension, because mechanical loading does not operate in isolation from the endocrine environment, and understanding how the two systems interact explains why heel drops are particularly important for adults over 50 rather than merely useful. Estrogen in premenopausal women partially suppresses osteoclast activity. When osteoclasts attempt to initiate bone resorption, estrogen limits the depth and duration of the resorption cavity they create. Estrogen withdrawal at menopause removes that suppression and osteoclast activity accelerates. The demolition crew works longer hours on deeper excavations. New bone formation, driven by osteoblasts responding to mechanical signals, now faces a more aggressive resorption environment. This does not mean mechanical loading becomes less effective after menopause. The osteoblasts remain mechanosensitive. They continue to respond to high-rate loading signals. The clinical data confirms this. But it does mean that the mechanical signal becomes more important, not less, in the postmenopausal period, because it is now the primary driver of bone formation in an environment where one major suppressor of bone loss has been removed. The woman of 60 who performs daily heel drops is not compensating for the loss of estrogen. She is activating the bone formation mechanism that was always osteoblast-mediated and always mechanically driven. She is using the system that aging has not dismantled, only underused. In men, testosterone decline is more gradual, and the bone loss trajectory is therefore less dramatic in the perimenopausal equivalent period, but the cumulative effect of decades of reduced mechanical loading, combined with the gradual decline in anabolic hormone levels after 50, produces the same fundamental deficit. The osteoblasts are waiting for a signal that contemporary sedentary life is not delivering. Heel drops deliver it. The parathyroid hormone connection is worth understanding. Parathyroid hormone, PTH, is the body's primary calcium regulator. When blood calcium falls, the parathyroid glands secrete PTH. PTH acts on bone to release calcium into the bloodstream, a process that requires osteoclast-mediated bone resorption. Chronically elevated PTH, which can occur with inadequate dietary calcium, vitamin D deficiency, or both, therefore chronically elevates osteoclast activity and accelerates bone loss. This is the mechanism behind the dietary calcium and vitamin D recommendations that dominate the bone health conversation. Adequate calcium and vitamin D maintain blood calcium levels, reduce the PTH stimulus for bone resorption, and create the chemical environment in which osteoblasts can work effectively. But note what that means for the relationship between nutrition and mechanical loading. Nutrition creates the environment. Mechanical loading is the signal. Adequate calcium provides the raw material for osteoblasts to use. High-rate heel impact loading tells the osteoblast to use it. You cannot build bone with mechanical loading alone if the raw material is absent. You cannot build bone with adequate calcium and vitamin D alone if the mechanical signal is absent. Both are required. The dietary advice and the mechanical advice are not competing, they are complementary. Most adults over 50 are receiving the dietary advice. Almost none are receiving the mechanical advice. This is the gap, and it is precisely why bones continue to thin in adults who are conscientiously taking their supplements, eating their dairy, and doing none of the impact loading that gives the osteoblasts their instruction to build. The protocol matters, because the dose of mechanical loading determines the magnitude of the osteogenic response, and the specific parameters of how you perform heel drops determine how much of the available signal you are actually delivering to the skeleton. 50 heel drops per day is the dose used in the most cited research on this intervention. That sounds like a significant number until you realize that at a comfortable cadence, it takes approximately 30 seconds to complete, not 30 seconds per set. 30 seconds total. The drops should be performed with deliberate intent, not passively. Rise fully onto the toes, reaching maximum plantar flexion to engage the calf fully and create maximum mechanical stretch in the Achilles tendon and the posterior chain. Then drop. not lower yourself gently. Drop with enough force and sufficient speed that the heel makes clear, audible contact with the floor, and you feel the impact travel upward. The rate of force development is the variable that activates the osteocytes. A slow, controlled lowering onto the heel delivers a different signal than a genuine drop. The difference matters biologically. Slow loading is slow fluid movement through the canaliculi. Fast loading is fast fluid movement. The osteocytes respond to rate, not just magnitude. Drop with intent. The sound is feedback. If the heel drop is silent, the rate of force development is insufficient. If it is audible, the signal is being delivered. Footwear matters here too. Performing heel drops in thick, heavily cushioned shoes absorbs the impact before it reaches the skeleton. The cushioning that makes modern athletic footwear comfortable for long walks is precisely the feature that attenuates the mechanical signal heel drops are designed to deliver. Perform them barefoot or in thin-soled shoes where the impact transmission is direct. Safety. Because the obvious question for any adult over 50 who has been told their bones may already be compromised is whether introducing impact loading is appropriate or whether it risks causing the very fractures it aims to prevent. This is a legitimate question, and the answer depends on the severity of existing bone loss. For adults with osteopenia, reduced bone density that has not yet reached the threshold of osteoporosis, heel drops are appropriate, and the research is specifically conducted in this population. For adults with confirmed osteoporosis, the intervention requires medical clearance and should begin conservatively, perhaps at 20 drops per day at reduced drop height, increasing gradually as confidence and tolerance build. For adults with existing vertebral fractures, the axial loading component of heel drops requires specific medical guidance and may not be appropriate without modification. The vast majority of adults over 50 who have not yet had a fracture and have not been diagnosed with severe osteoporosis are appropriate candidates for this intervention. The forces involved in a controlled heel drop are lower than the forces involved in jogging, in jumping, in stepping off a curb, in most of the activities that adults with mild to moderate bone loss perform daily without concern. The intervention is lower risk than most people assume and higher benefit than most people have been told. The consistency principle applies here with particular force because the osteogenic response to mechanical loading is not produced by occasional high-intensity sessions. It is produced by frequent, regular, brief exposures to the stimulus. The osteocytes in the bone matrix respond to each impact event and initiate the biochemical cascade, but the cascade requires repetition to accumulate into measurable structural change. Research on bone adaptation to loading consistently shows that the skeletal response saturates relatively quickly within a single session. Performing 50 heel drops produces a meaningful osteogenic signal. Performing 500 heel drops in the same session does not produce 10 times the response. The osteocytes become relatively refractory after a certain number of loading cycles and require a period of rest before they recover full mechanosensitivity. This is why the protocol is 50 drops daily rather than 350 drops once a week. Daily brief exposure outperforms weekly high-volume exposure for bone formation. The biology favors frequency over volume. 30 seconds every day produces greater skeletal adaptation than 3 minutes once a week. This matches the rhythm of daily life in a way that structured exercise programs rarely do. It requires no scheduling, no commute to a gym, no equipment preparation, no change of clothes. It can be performed standing at a kitchen counter while waiting for coffee to brew, standing at a bathroom sink after brushing teeth, standing at a desk during a phone call. The barrier to entry is essentially zero, and the biological requirement for frequency means that the low barrier is a feature, not a compromise. What happens in the body over weeks and months of consistent practice is a story of incremental architectural reinforcement. The first weeks produce no measurable change in bone density. Bone remodeling operates on a timescale of months, not days. The osteoblast response to mechanical loading takes time to translate into measurable mineral deposition, but the biochemical cascade is running from the first session. Osteocytes are signaling. Osteoblasts are being recruited. The remodeling balance is tilting. At 3 to 6 months of consistent daily practice, measurable changes in bone mineral density begin to appear at the loaded sites in studies using dual-energy X-ray absorptiometry, the DEXA scan that quantifies skeletal density. The hip shows the first changes because it is anatomically closest to the transmission path of the heel impact signal. The lumbar spine shows changes subsequently. The changes are not dramatic in absolute terms. A 1 to 3% increase in bone mineral density at the hip over 6 to 12 months of consistent loading may sound modest until you consider that an untreated postmenopausal woman loses approximately 1 to 2% of hip bone density per year. The difference between losing 1% and gaining 2% is a 3% annual swing in the structural capital of the most fracture-vulnerable site in the aging skeleton. Compounded over 5 years, that difference is the difference between a hip that holds and a hip that breaks. The balance benefit arrives earlier than the bone benefit and is worth naming separately because it matters independently. The mechanical act of rising onto the toes and dropping onto the heels engages the calf musculature, the intrinsic foot muscles, the ankle stabilizers, and the postural chain from the foot to the lumbar spine. Performed daily, the exercise progressively strengthens the exact muscular system that prevents falls. The calf complex, gastrocnemius and soleus, provides the reactive ankle stiffness that catches a stumble before it becomes a fall. The intrinsic foot muscles, chronically weakened by decades inside supportive shoes, provide the fine proprioceptive feedback that tells the nervous system where the foot is in space and whether the surface beneath it is stable. Heel drops train both. The rising phase strengthens, the dropping phase loads, and every repetition sends proprioceptive signals through the ankle and foot that sharpen the neural map the cerebellum uses to maintain upright balance. Falls cause fractures. Preventing falls is therefore bone protection by another name. The exercise that builds bone is simultaneously training the system that prevents the fall that would break it. The two benefits are not parallel, they are synergistic. Stronger bones and better balance together reduce fracture risk more than either does independently, because fracture risk is the product of bone strength and fall probability. Reduce both variables simultaneously with the same 30-second daily practice, and the compound effect on fracture risk is substantial. 10 minutes of walking maintains the minimum. 30 seconds of heel drops changes the signal. The distinction matters because they are not interchangeable and they are not competing. Walking provides cardiovascular benefit, mood benefit, circadian rhythm support, and the low-level mechanical loading that maintains basic skeletal maintenance. It does not deliver the high-rate impact signal that osteocytes require to initiate new bone formation. Heel drops deliver that signal in 30 seconds and ask nothing else of your schedule. The person over 50 who walks daily and performs heel drops daily is not doing more exercise. They are doing different exercises that address different biological requirements. The walk addresses the heart and the mood. The heel drops address the skeleton. Neither one covers for the absence of the other. For the 55-year-old who has been quietly losing bone density for 20 years while conscientiously taking calcium supplements and vitamin D and walking every morning and assuming that was sufficient, the information in the research literature is uncomfortable but important. The supplements were creating the environment. The walking was providing the minimum. The signal the osteoblast needed to actually build was never being delivered. 30 seconds a day was always enough to deliver it. The floor was always there. The heels were always there. The only thing missing was the knowledge that dropping them with intent 50 times every morning sends a message directly into the bone that no pill, no powder, and no gentle stroll has ever been able to replicate. The skeleton is listening. It has always been listening. It responds to what you ask of it. You just have to learn the language. The language is impact. The sentence is 30 seconds. Say it every day.